Welcome to the deep dive. Okay, today we're plunging into a condition that can really sideline even the most powerful equine athletes, equine arytenoid chondropathy. And this isn't just, a simple cough we're talking about. It's a pretty profound challenge to a horse's actual ability to breathe. It impacts everything from performance on the track to just their daily comfort. So our mission today is to kind of cut through the medical jargon, understand what's really going on, and maybe find those surprising insights that explain why this condition is such a big deal for anyone involved with horses.
Yeah, and what's truly fascinating, I think, is how an issue that seems quite localized, just in the larynx, can have these huge ripple effects. It can severely compromise a horse's whole athletic future and just its general well-being. So we're going to try and unravel not just what it is, but really why it poses such a significant hurdle for owners and vets alike.
Okay, let's start right there. What exactly is equine arytenoid chondropathy? Laying the groundwork.
Well, fundamentally, it's an inflammatory process, and often an infectious one too, that targets these things called the arytenoid cartilages.
And these aren't just random bits of cartilage, are they? They have a specific job.
Not at all. You can think of the arytenoid cartilages as basically the crucial gateway to the windpipe, the trachea. They're these paired structures inside the larynx, and their vital job is to open up wide. The technical term is abduct when the horse breathes in. This action is absolutely essential for getting maximum airflow, especially, when a horse is really exerting itself, like during intense exercise.
Right. So when this chondropathy thing strikes, that gateway starts to fail. You're saying these cartilages swell up, they deform.
Exactly. They swell, they can change shape, and you might even see things like granulomas, sort of like fleshy masses forming on them.
So it physically blocks the airway. It's like
Right.
like trying to breathe through a straw that's collapsing.
That's a really good analogy, yeah.
Right.
It physically obstructs the airway, prevents those cartilages from opening fully. Sometimes they even get pulled inwards during breathing.
And you hear about kissing lesions? What's that?
That's where the swelling is so bad that the two opposing cartilages actually start rubbing against each other during breathing or exercise, causing further irritation and damage.
Okay. And who gets this? Is it any horse?
Well, technically it can affect older horses of any breed, but we see it most commonly, I'd say, in high-demand athletes.
Okay.
Race horses, young male performance horses particularly, which makes sense, right? The intense airflow needed for their jobs really puts stress on that area and can worsen any underlying problem.
So what triggers it? What actually causes this cascade of inflammation and infection? It seems very specific to that spot.
Yeah, the exact initial trigger isn't always crystal clear, but the general understanding is that it typically starts with some kind of primary injury, maybe just a small one, to the mucosal lining, the delicate surface layer of the larynx, often right over the arytenoid cartilage.
Like a tiny scrape.
Sort of, yeah. And that initial damage, that little break in the lining, it basically acts like an open door. It allows bacteria to get in. And once bacteria invade the cartilage itself, that's when you get the deep-seated infection and the significant inflammation we call chondropathy. It's quite surprising sometimes how a seemingly minor irritation can snowball into such a severe chronic problem in these animals.
And these initial injuries, where do they come from? You mentioned physical trauma.
Right. It could be from just the force of turbulent air during really intense exercise, or inhaling irritants like fine track dust or particles. Even something like severe prolonged coughing can physically damage the lining, or sometimes medical procedures like having a tube passed for anesthesia or stomach tubing.
Okay, so physical stuff. What about infections?
Yeah, definitely. Upper airway infections, whether they're viral or bacterial, often lead to coughing. If that coughing is persistent, it can cause those contact ulcers on the cartilage surface. And if the inflammation from that lingers and a secondary bacterial infection takes hold on the cartilage, boom, you've got cartilage sepsis.
Are there other irritants too?
Sure. Things like inhaled allergens, maybe swallowing a foreign object that scrapes the area, even gastric reflux, stomach acid coming up, can irritate the larynx lining.
And you mentioned those kissing lesions. Again, so the repetitive contact itself during hard work can actually injure the opposing cartilage. It's like a vicious cycle.
Exactly. It can perpetuate the problem. And this condition, it usually progresses, right? It doesn't just stay the same.
No, it tends not to. It often starts acutely, that initial inflammation and swelling.
But if it's not caught and treated effectively early on, it can pretty quickly shift into a chronic state. And that's where you get irreversible changes. The cartilage gets permanently enlarged, distorted, scarred up, and all that narrows the airway.
So the takeaway is that early detection is key before it gets chronic.
Absolutely paramount, because once that cartilage structure is severely damaged, it's much harder to fix. Oh, and a really crucial diagnostic pointer.
Mm.
It's almost always unilateral, just affects one side.
Inside only.
Usually, yes. And here's the interesting bit. If you happen to see the right arytenoid affected, chondropathy should jump right to the top of your suspicion list.
Why the right side specifically?
Because the other common cause of airway noise, laryngeal hemiplegia, what people often call roaring, is overwhelmingly a left-sided problem. It's incredibly rare on the right. So right-sided issues strongly suggest chondropathy.
Okay, that's a really useful clinical pearl. So for listeners, owners, trainers, what are the big red flags? What signs should make them think, maybe this is what's going on?
Well, the two absolute classic signs are exercise intolerance. The horse just can't perform like it used to, and a very specific kind of abnormal respiratory noise.
That noise, it's pretty distinctive, isn't it? People describe it as whistling or roaring.
Exactly. It's often this high-pitched whistling or roaring sound, usually heard when the horse breathes in, that's inspiratory stridor, and it gets worse, typically the harder the horse works.
Can they make noise breathing out too?
Sometimes, yes, expiratory noise can happen. But that inspiratory sound is really the hallmark of upper airway obstruction like this.
And connecting that to performance, it gets worse over time?
Usually, yeah. It tends to be progressive. And the more intense the exercise demand, the earlier you'll notice the problem. Racehorse trainers might say the horse just doesn't finish its races anymore. It can't sustain that final push.
And for show horses?
For show horses, it might be less about stamina and more about the noise itself actually causing them to lose points in competition. Judges penalize for abnormal respiratory sounds.
Okay, noise and poor performance. Are there other, maybe more physical signs to watch for?
Yes, definitely. Coughing is pretty common, either during exercise or right afterwards. In cases that are severe, or if it happens to affect both sides, which is less common but serious, you might see actual difficulty breathing, what we call dyspnea, even when the horse is just standing in the stall.
What does that look like?
You'd see things like flared nostrils, maybe an anxious expression, and you'd see their abdominal muscles working really hard to help them breathe. It's quite obvious distress.
Anything else? Less common signs?
Less commonly, yeah, you might see difficulty swallowing, that's dysphagia. Or maybe a fever if there's a really acute, active infection going on. And in really chronic, severe cases where breathing is consistently hard work, the horse might actually start to lose weight.
Wow, okay. So with all these possible signs, how does a vet actually pin down the diagnosis? You said it requires a few different things.
Yeah, exactly. It's rarely just one test that gives you the answer. It's what we call a multimodal approach.
So starting with the basics, history, exam.
Absolutely. A really detailed history from the owner or trainer about the symptoms when they started, how they've progressed, what makes them worse. That's crucial. Then a thorough clinical exam. Sometimes the vet can actually feel thickening or asymmetry, or the horse might react painfully when they palpate the larynx from the outside.
But the real key is looking inside, right? Endoscopy.
Endoscopy is the absolute cornerstone, yes. Looking inside the airway with a camera. First, usually a standing endoscopy, just with the horse at rest.
And what does the vet see then?
Well, it depends on the stage. In acute cases, they might see obvious swelling, redness, maybe even some pus if there's an abscess. But in chronic cases, the appearance is pretty distinctive. The affected arytenoid cartilage looks enlarged, it's misshapen, thickened.
Right.
It loses that normal, crisp, triangular or sort of heart shape it should have.
And you can see if it's moving properly.
Critically, yes. They'll watch the horse breathe and assess the movement. They'll look for restricted movement or even complete failure of that cartilage to abduct to open up. They might also see granulation tissue, those fleshy masses we mentioned, or ulcers on the surface, or even bigger cartilaginous lumps called chondromas sticking out into the airway.
And those kissing lesions again?
And yes, they'll look for evidence of contact between the two cartilages, those kissing lesions.
But you need to see them exercise too sometimes.
For performance horses, yes, dynamic endoscopy is highly recommended. This involves putting the endoscope in place and then having the horse exercise, usually on a treadmill or sometimes ridden. This allows the vet to see exactly how the larynx functions under the stress of high airflow. It's really important for differentiating chondropathy from other conditions that only show up during exercise, like laryngeal hemiplegia or palate issues.
Makes sense. What about other tools besides the camera? Ultrasound.
Laryngeal ultrasonography is actually a really valuable addition. It uses sound waves to look through the skin at the structure of the cartilage itself. It can help assess the size, the thickness, see if there are pockets of fluid like abscesses inside. They show up as dark, hypoechoic areas. Or if there's mineralization, which is common in chronic cases that looks bright, hyperechoic. Ultrasound is also good for comparing the affected side to the normal side, and it helps rule out other things too.
Okay. What about more advanced imaging, like X-rays or CT scans?
Radiography, or X-rays, has pretty limited use for the soft tissue details here, but it can sometimes show mineralization in those really chronic cases. But CT computed tomography and MRI magnetic resonance imaging, they provide incredibly detailed cross-sectional images. You can see the cartilage structure, any abscesses, the degree of swelling, relationship to surrounding tissues, and amazing detail.
But there are downsides.
The main ones are that they require the horse to be under general anesthesia, which always carries some risk, and they tend to be quite a bit more expensive. So they're usually reserved for more complex cases or for surgical planning, not typically the first step.
Gotcha. And lab tests, blood work.
Lab tests can be helpful too. If there's an active infection, blood work might show elevations in inflammatory markers, things like serum amyloid A or fibrinogen. That tells you there's active inflammation systemically.
Can you test breathing directly?
You can, yes. Arterial blood gas analysis during maximal exercise can show if the horse isn't getting enough oxygen or clearing enough carbon dioxide, which points towards significant airway obstruction. You'd see low PO2 and high PaCO2.
And if you see pus?
If there's obvious pus or discharge visible during endoscopy, getting a sample for culture and sensitivity testing is really important. That identifies the specific bacteria causing the infection. Often it's Streptococcus species, but it could be others, and tells the vet exactly which antibiotics are most likely to work. Helps target the treatment effectively.
Right. Targeted treatment is key. So let's talk treatment. Once you have that diagnosis, what can actually be done? Is surgery always the answer?
That's a really critical question, and the answer is it depends. Treatment strategy really hinges on a few things: how advanced the disease is, how badly the airway is obstructed, and importantly, what the horse is used for its athletic goals. So no, it's not always surgery right off the bat.
Okay, so what about medical options first? For earlier cases, maybe?
Exactly. For acute cases, or maybe mild chronic cases where there isn't huge distortion yet, medical management is often the first approach. This typically involves a long course of broad-spectrum antibiotics, and I mean long, often several weeks, sometimes even months, to try and penetrate that cartilage and clear the infection.
Alongside antibiotics.
You'd use anti-inflammatory drugs.
Mm.
NSAIDs like phenylbutazone or flunixin are really important to reduce the swelling and pain. Sometimes, in very acute swollen cases, veterinarians might use corticosteroids like dexamethasone carefully because systemic steroids have potential side effects. There are also some specific throat sprays that can deliver anti-inflammatories locally.
And rest, I assume.
Oh, absolutely non-negotiable. Strict stall rest is vital to minimize any further irritation or stress on the larynx and allow things to calm down and hopefully heal.
What if the horse is really struggling to breathe right then?
In those acute, severe cases where the swelling causes significant respiratory distress, a temporary tracheostomy might be necessary. That's creating a temporary surgical opening into the windpipe in the neck to bypass the obstruction and provide an immediate, safe airway. It's a life-saving measure sometimes.
Okay, so that's the medical route. When does surgery come into play?
Surgery is generally considered for the more chronic, severe cases where the cartilage is already significantly deformed and scarred, or when medical management has been tried and just hasn't worked well enough to restore adequate airflow. The primary goal of any surgery here is always to open up that airway.
Are there less invasive surgical options?
There are some minimally invasive techniques, yes. Things like laser debridement or granulome excision.
Yeah.
This is done using a surgical laser path through the endoscope. The laser vaporizes away obstructive granulation tissue or can be used to drain small abscesses within the cartilage.
And who's a good candidate for that?
It's generally best suited for cases with smaller lesions where there's still some reasonable arytenoid movement remaining. The advantages are that it's less invasive than open surgery, usually has a faster recovery time. But the disadvantages are that there's a risk the problem could recur, and there's always a small risk of thermal damage from the laser.
Okay. But for the more serious deformed cartilage cases, what's the main surgical fix?
The most common and often most effective procedure for significant chronic chondropathy is what's called a partial arytenoidectomy.
Partial meaning you remove part of it.
Exactly. Under general anesthesia, the surgeon removes the deformed portion of the arytenoid cartilage, usually the corniculate process and maybe part of the body. The aim is to physically remove the obstruction and permanently widen that side of the laryngeal opening.
And does that work? Can horses go back to performing?
It can significantly improve airway patency, yes, and many horses can return to some level of athletic performance afterward.
I sense a butt coming. What's the catch?
Well, here's the critical part for owners to understand. Partial arytenoidectomy is a major surgery, and it's not without potential complications. The most significant ones are post-operative coughing and difficulty swallowing, which we call dysphagia. Because you've removed part of the structure that helps protect the airway during swallowing, these horses are at a much higher risk of inhaling food or water.
Which leads to...
Aspiration pneumonia, which can be very serious, even life-threatening. So careful management after surgery is crucial. Also, sometimes scar tissue can form during healing and cause some re-narrowing of the airway, though usually not as bad as before.
And the return to top-level performance.
While many horses improve and can perform at a level, the success rate for returning to elite levels, especially in something demanding like racing, is generally considered lower after a partial arytenoidectomy compared to, say, surgery for simple roaring. Owners need realistic expectations.
Okay. What if both sides are affected? Can you do surgery on both?
A bilateral partial arytenoidectomy removing parts of both cartilages is very rarely done. The risk of severe, unmanageable dysphagia and aspiration pneumonia is extremely high. It's usually only considered as a salvage procedure for horses, not intended for any kind of athletic career, just to improve breathing at rest.
So what's the last resort if surgery isn't an option or doesn't work?
For those really severe, untreatable bilateral cases, or maybe cases where surgery isn't feasible for other reasons, and the airway obstruction is truly life-threatening, a permanent tracheostomy might be performed. This creates a permanent opening from the skin surface directly into the trachea in the mid-neck region.
So they breathe through their neck.
Essentially, yes. It completely bypasses the larynx. It provides a guaranteed open airway which can save the horse's life and allow for comfortable breathing. But it requires very diligent daily cleaning and care by the owner to prevent blockage and infection, and it generally eliminates the possibility of the horse being used for strenuous athletic work.
Right, a big commitment. And after any of these surgeries, what's the recovery like? What does post-op care involve?
Post-operative care is intensive and really critical for a good outcome. It always involves continued antibiotics, often for several weeks, and anti-inflammatories to manage pain and swelling and prevent infection. Often, a temporary tracheostomy tube is left in place for a few days, maybe even up to a few weeks after a partial arytenoidectomy, just to ensure the airway stays open while the initial swelling goes down.
And watching for those complications.
Absolutely. Close monitoring for any signs of dysphagia, coughing when eating or drinking, or signs of aspiration pneumonia, like fever or increased respiratory rate, is essential. Vets will usually recommend feeding soft mashes or soaked feeds initially to make swallowing easier. And then it's a very gradual return to exercise. Hand walking first, then maybe light turnout, slowly building up over weeks to months, carefully watching breathing and listening for noise. It's a long rehabilitation process.
Okay, so it's quite the journey. After all that, medical or surgical, what's the bottom line? What's the prognosis? What kind of life can these horses expect?
Yeah, the outlook, the prognosis, it really does vary quite widely. It depends so much on how severe it was to begin with, which treatment was used, and how well the horse responded. For those early mild cases caught quickly and treated aggressively with medical management, the prognosis can actually be quite good. Some of those horses can potentially return fully to their previous level of function.
And for the ones needing surgery, the partial arytenoidectomy cases.
For those moderate to severe cases, many horses do achieve a satisfactory outcome. They can breathe much better, be more comfortable, and often return to some level of performance, maybe pleasure riding, lower-level competition. But as we discussed, achieving that same peak, high-level performance, especially in racing, can be challenging. The stats for return to racing aren't as high as for simpler laryngeal surgeries.
And owners need to be aware of the risks.
Absolutely. It's crucial that owners understand going in about the significant risk of those post-operative complications, especially the coughing and the potential for aspiration. That needs careful management and monitoring long-term in some cases.
What about the horses where surgery isn't really an option, or maybe it fails, the permanent tracheostomy cases?
For those horses, while it's a big management change, a permanent tracheostomy can still allow for a good quality of life. They can often live comfortably, pain-free, as pasture companions, or perhaps for very light, non-strenuous pleasure riding. It requires dedicated owner care, but it provides a solution for otherwise life-threatening airway obstruction. Thinking about all this, it really brings up an important point, doesn't it? In this world where we push equine athletes right to their physiological limits, how do we balance those performance expectations with providing really compassionate, effective care when complex conditions like this arise? It's a tough balance sometimes.
It really is. So today, we've taken a pretty deep dive into equine arytenoid chondropathy. We've uncovered, I think, some surprising complexities behind what might just seem like a breathing issue. We've walked through that meticulous diagnostic journey vets have to take and explored the challenging but often hopeful treatment pathways. Hopefully for you listening, this has been a bit of a shortcut to being really well informed on a condition that, let's face it, often gets hidden behind a lot of complicated medical terms.
Yeah, and if he sort of connect this to the bigger picture, the whole story, arytenoid chondropathy, it really underscores this incredible intersection of, physiology, pathology, and just sheer dedicated veterinary and owner care that's needed to support these amazing animals. It's a reminder, I think, that even with all our advanced medicine, that journey from getting a diagnosis to hopefully reaching recovery, it's often just a huge testament to resilience, both from the horse and from the humans caring for them. So here's a final thought for you to maybe chew on. What really stands out to you about just how much goes into keeping these incredibly powerful creatures performing at their best, or even just living comfortably day to day? And how might understanding something like this deep dive, maybe change how you view the demands we sometimes place on them?